CP angle system and doesn't affect the auditory nerve anymore. Whatever size it may be, you may have 5 centimeter acoustic yet not affecting the facial nerve clinically because it has an enormous capacity to stretch. Yet without being giving a clinical paralysis, yet the nerve being so thin like a ribbon, like very few fibers, still in continuity and still maintaining the clinical, integrity of the facial function.
Yes.
That is something beauty about this nerve. So now the fourth function, that is the fourth nerve, which is unaffected at the facial nerve. And the entire, the core of the treatment now is directed to preserve the facial nerve in future.
Yeah.
Now it has been studied. Tumors which are growing more, as I said, the nerve is more and more stretched. It has sometimes a common blood supply from the facial nerve and the tumor, which has. So bigger the tumor it is, more the nerve is stretched, and then you remove the tumor, more are the chances of giving some sort of facial paresis or paralysis.
Yeah.
It has been generally observed for tumors more than 2 centimeters or so. It is so difficult to preserve the facial nerve function to completeness. You may have some sort of paralysis, some more paralysis, whatever, but you will never find a normal facial nerve function after in such a big tumors.
Very true, very true.
So now we have already lost the hearing. We have nothing more to lose. Now this is the best opportunity to preserve the facial function.
Right.
And for such a small tumor of the size I will measure and show you, this is the best opportunity to preserve the facial function. Now let me see the size of this, tumor. See, 9
millimeter
by 4 millimeter or 5 millimeter, whatever, is the size of the tumor. And with this size tumor, it has been studied, our experience also in our hundreds of such cases done, the smaller ones. This is the best opportunity to preserve the facial nerve. Okay? So
if the hearing was, Satish, if the hearing was okay, what would you do?
Yes, that's a question for master. Then would be the decision making would be more, difficult. If hearing is normal in such tumors, small canalicular tumors identified as incidentalomas on MRI imaging, or on certain symptomatology, if you find such tumor, now the decision making depends upon so many things. Number one, majority of these small tumors, the first strategy is to observe. Observe with serial MRIs, and all these tumors do not grow substantially.
You're right.
A chunk of tumor, more than 50% tumors, either do not grow or grow very slowly, and you can manage on a serial MRI until they show substantial growth. Substantial growth means more than 3 millimeter growth every year. To me, it is substantial growth. Until then, you can observe unless it gives some complications. Now, there are certain patients, the age is an important consideration. Small canalicular tumor in elderly, the first and the foremost strategy is observation.
Exactly.
Since they are slow growing tumor, if the patient is 65 and above, you can very well observe for years together because the life expectancy is not so much. If you can consider as 80 years as a life expectancy, you don't need to bother, you can observe. And in case if it starts growing, in that situation, you can use your gamma knife or something to control the growth, to, contain the growth. So in elderly is a different scenario. In young patients, you have to give a cure rather than gamma knife. This is simple, one thing we know. Radiation is never reserved as a first choice for young people for any regions. And for young people, if the patient has hearing loss, then obviously like this patient who has already lost hearing, there is the best chance to give him a cure as well as preserve the facial function. If the hearing is intact, I would observe.
Absolutely.
Observe until it gives substantial growth, until it gives hearing loss, until it gives, sometimes this definition of hearing loss should be understood. It is not the pure tone audiometry which, clarifies the quality of hearing loss. It is along with that the speech discrimination score, which is more important. So when you start losing the, the quality of hearing when you use required for the day-to-day purpose, or what you call it as a, you know, good hearing in terms of day-to-day use, then you have to think of surgery in number one. Number two, when the patient present with dizziness,
Yeah.
when vertigo, unsteadiness is a major problem. Maybe
Mhm.
elderly patient for that reason. Maybe elderly patient when vertigo is the presentation, and unsteadiness, which is long lasting, not relieving, when the compensation is not happening, then surgery is the answer to treat both the tumor as well as taking away the afferents to relieve vertigo. What my point? So,
Yeah, Satish, in your experience, how many
yeah,
patients do you see presenting with vertigo as a primary symptom?
less than 10%.
Yeah, right. Yeah, yeah.
Less than
Very,
10%.
very low, very low.
So that's why I mentioned in the last,
Mhm.
very low percent of the patient. But yes, a patient present with vertigo, I have seen patient with incapacitating vertigo, with
Okay.
small intracanalicular tumor, and we had
Mhm.
to operate upon that and relieve the vertigo.
Okay.
Because sometimes these, persistent vestibular afferents are more disturbing than no afferents, What's my
So,
point?
so suppose the patient is young and we opted for a conservative management. How will you follow up the patient?
Serial MRI. First is annual MRI. Then once in 2 years, until it doesn't show any growth. If it shows growth, then start showing growth, then you can get it done 6 monthly and it still shows growth. You have to better to discuss with the patient for the removal, because this is something which requires a lot of decision making with the patient as well. Patient choice is sometimes a very important factor, because this is a major surgery. This is the surgery where you result in CSF leak, and there are always possibility of complications. Theoretical possibility, though in the present situation you can handle all these in the best way, but still you have to discuss with the patient decision making. Sometimes patient, in spite of everything, they want to live with it without getting any problem, because there is always, you cannot guarantee facial nerve preservation even in the small tumors.
Exactly.
So the decision making is important to discuss with the patient. Now, those patients, suppose this is a very small tumor. Had this been little bigger one and cystic tumor, I would straight away suggest a surgery in cystic tumors, whatsoever the size it is.
You're right.
Because cystic tumor tend to progress very fast, and in larger tumor, in case they grow larger, preservation of the surrounding neurovascular structure become very, very difficult unless you leave behind the wall.
Yeah.
So these are the important factors in decision making, whether to operate or not. Then there are certain issues. Once you operate, then what approach one can think of? See this, there are many approaches in vestibular schwannomas. The translab is the approach which inherently sacrifices the hearing. That is the biggest disadvantage. Every approach has its own advantage and disadvantage.
Yeah.
So the translab has an advantage, I will mention, but the disadvantage, it sacrifices the hearing completely. So in decision making, any patient who has already lost the hearing, whatsoever size the tumor is, the preferred approach is the translab. Whatsoever size means maybe a 5 centimeter acoustic, yet you can remove through the translab, because this is the tumor which has a well preserved arachnoid, layers all around. It's not that through the translabyrinthine view, the entire tumor in one go should be visible all around. You can debulk the tumor, you can mobilize the non-visible part of the tumor in the field then, and you can again debulk and keep mobilizing the rest of the tumor in the field and remove it.
Yeah.
So size is not a criteria for choosing the approach for that matter. The other two approaches, retrosigmoid and middle cranial fossa, have an ability to preserve the hearing, and they have their different, advantage and disadvantage. Let me quickly go through in 5 minutes so that we can take decision making. I'll skip this. So conservative management, as we already discussed, in patients with advanced age, short life expectancy, slow growth, patient who are not fit for surgery or minimal symptoms, only hearing here. This is one of the important criteria to observe as long as possible, as long as the hearing is intact. Now, suppose the tumor has grown to a bigger size and started compressing the hearing. What you can think is, you can decompress by the retrosigmoid route. You can
Yes.
decompress. You can, decompress the posterior wall of the intra-auditory meatus to accommodate more tumor without exerting pressure on the cochlear nerve. A sort
Yeah.
of decompression. Remove the posterior lip of the intra-auditory canal to allow the tumor to expand and leave the pressure from the auditory nerve, something like that. So you can debulk, you can use a gamma knife, as long as you can, wait, you can avoid surgery in the only hearing ear. And in case required, you can implant the other side. The other ear who has a profound loss, you can implant the other side and get the good hearing. Once you get the good hearing with the implant on the other side, then you can take on a call to extirpate this tumor on the opposite side. Okay.
Yes.
So these are important decision-making factors like you asked. So by and large, any tumor, see this is a simple algorithm. Any tumor which has lost the hearing, the translab is the approach. Otherwise, any tumor which is more than 1.5 centimeter, what we believe, tumor which is more than 1.5 centimeter is practically difficult to preserve the hearing. Serviceable hearing. Even if your pattern shows 50 dB hearing loss, get the SDS done, it will be poor. Because the more the tumor grows, it affects the cochlear nerve. Like this patient, what happened? Where we have two vestibular nerves, superior and inferior. The inferior one is in close proximity to the cochlear nerve. So tumor which arise from the inferior vestibular nerve, they affect the cochlear nerve early in their course and present with hearing loss. What we believe in this patient, which is such a small tumor presented with hearing loss, must be arising from the inferior vestibular nerve and presented early with the hearing loss. Got my point?
Right, sir. I mean, very clear algorithm.
Otherwise, it is so difficult to predict in a larger tumor whether it is arising from inferior or superior vestibular nerve. Though you can do a calorie test. Still, if you are getting caloric responses, means lateral canal responses, if you are getting, that means your superior nerve is intact and still tumor from the inferior nerve, but it is difficult then in a larger tumor. So, by and large, for larger tumors, whatsoever the hearing is, it is never, it is rarely possible to preserve the serviceable hearing, and better is to do a translab. A distorted hearing is worse than no hearing.
Absolutely.
So it is
So your
better
bad
to...
hearing thing would mean actually speed discrimination scores as a criteria, right?
Yes. Now, when the patient has good hearing, like you have asked, see this, for smaller tumors, good hearing, if the tumor is intracanal, like this tumor, being intracanalicular, good hearing, and you wanted to operate, the best would have been middle canal fossa. That to a laterally placed tumor. This is a laterally placed tumor. Even the retrosigmoid approach is a hearing preservation approach. For intracanalicular tumor, retrosigmoid is a good approach if the tumor is medially placed. Got my point?
Got it.
You can drill the medial canal and you can remove the tumor easily. But for such laterally placed tumor, this is never a good case for retrosigmoid, because you have to all the way come in the lateral part of the canal, drilling the canal, and you don't see the lateral end of the canal and remove indirectly and end up losing the hearing. For defeating the purpose you started off. So, had this patient been having a good hearing, would have been the ideal case for the middle canal fossa approach, because this gives you the fantastic exposure of the lateral part of the canal, for that matter, entire canal, yet preserving the hearing. The only concern to me about the middle canal fossa approach, there are three concerns, I would say. Number one, it is a difficult approach than any of all the approaches.
Yes.
Number two, in elderly patient, this is not a good approach, because you have to elevate the dura a lot till the petrous apex base and retract it. And dura in the elderly patient is very friable, and you can end up, tearing the dura. Third is you have to retract the temporal lobe a lot sometimes. And those patients who had history of epilepsy, who had issues in the intracanal issues, and all that. We avoid this. And fourth is, see, let me show you through a picture. Yes, see this architecture of nerves in the intra-auditory meatus. Antero-superiorly is facial now. Hello?
Yeah, we can hear you. Yeah.
Posterior-superiorly is,
Superior vestibular. Mhm.
this is inferior vestibular now. Now, coming from superior, this view, this route, most of the tumor, 90% of the tumor arise from the inferior vestibular now.
Yeah,
In
yeah.
order to reach tumors arising from the inferior vestibular now, small canalicular tumor, you have to manipulate the facial nerve.
Yeah, yeah.
Coming from here, you have to always manipulate the facial nerve, retract it, and some sort of facial paresis happens
right.
to take place. So you are removing the tumor by the middle cranial fossa approach at a lot of cost.
Mhm.
I have already mentioned the concerns about retracting the temporal lobe, dural difficulties, and then the facial paresis. Many of these patients, manipulating the facial nerve results in some sort of facial paresis. That is the biggest
Absolutely.
concern with the middle cranial fossa approach. So you have to choose the approach according to the case. So translabyrinthine, what we are discussing today, has a lot of advantages. I will show you. The best advantage is it has the most direct access to the CP angle. What do I mean? Let me take you to the MRI. See this. This is CP angle. Can you see?
Yeah, yeah.
If let me show you. If I come from here as a straight line through the labyrinth, can you see?
Yeah, yeah, we can see it.
The most direct approach I will show surgically. You drill the temporal bone and you straight reach to the CP angle, head-on approach.
Mhm.
From the retrosigmoid approach, what happens? This is your sigmoid sinus here. So you have
Yeah,
to
yeah.
go from behind the sigmoid sinus and attack from behind. So this is a different angle. This is not a head-on approach to the CP angle for that matter. Number two, this translab gives direct access to the intra-auditory canal. See this?
Yeah, yeah.
See this? Direct access. With retrosigmoid, if you want to reach out this part of the canal, you have to drill the posterior lip of this canal, and then drilling, reach out here, and you have no landmarks. You can end up damaging the inner ear organs and end up losing the hearing. So the advantage of the translab is most direct access, no retraction of cerebellum, and the first thing you identify once you open the lateral end of the canal are the cranial nerves.
Yeah, yeah.
Most easier to identify the facial nerve than any of the other approaches. So in this case, I will show you first the facial nerve. I will show you this tumor is so laterally placed, you will be directly onto the tumor and the facial nerve there behind. What's my point? So in any given
Very
case,
clear.
this is the approach which allows earliest positive identification of the seventh cranial nerve in the beginning of the procedure. In retrosigmoid, you don't, because in retrosigmoid, you go behind the, see if your tumor is here, suppose let me make out as some sort of tumor. See, if my tumor is here, suppose this is the tumor. What's my point?
Yeah, yeah, got it. Got it.
This facial nerve runs on the stretch anteriorly and superiorly from the tumor. Since it arises
Yeah.
from the inferior vestibular, now the facial nerve is going on the anterosuperior part of the tumor. In retrosigmoid, you have to go all the way across the tumor to see the facial nerve behind.
Mhm.
What's my point?
Yeah, got it.
So that is never a direct approach. So this translab is the one which allows you to identify the seventh nerve at the beginning. It gives you the best exposure of the intra-auditory canal circumferentially. I'll open up the entire intra-auditory canal and show you. Okay? And
Yeah.
since the bony cavity they are in the canal, you can you can control the CSF leak very well, because in this approach you obliterate the entire lateral cavity after that.
Yeah, yeah.
What's my point? So this
Got
gives
it.
the least risk of CSF leak as compared to the other approaches. No
Mhm.
other approach requires fat obliteration, cavity obliteration.
Yeah, yeah.
That requires a cavity obliteration, and this gives you the best opportunity to prevent the CSF leak. What's my point? In
Got it.
case post-operatively hematoma or anything happens, In the retrosigmoid, your cerebellum, you retract it, it swells up. You can't go easily back into the same area easily with a swollen cerebellum. Here you remove the fat and you are back onto the place in a minute, without wasting any time. In that situation, if you need to re-explore, okay?
Got it.
But obviously, it has disadvantage also. I already mentioned the hearing is always sacrificed as an inherent part of this approach. And secondly, sometimes technically difficult when your jugular bulb is anterior place, your sigmoid sinus is so superior, and you have hardly any space to deal with the tumor, for instrumentation and dealing with the tumor. So narrow access is a relative contraindication. With experience, you can deal with that as well. Okay.
Oh, yes.
So anything else, Manoj, you want me to?
No, this contrast in, we always advise MRI with contrast in case of sudden initial. You would always order a contrast, Satish, or would you are okay with the flare?
No, contrast is always required. And we have the contrast. See, contrast is required for differential diagnosis,
Yeah.
See, there could be many lesions in the CP angle and you have to have a differential diagnosis. Let me tell you, in this particular patient, there's the contrast imaging coming up. Yeah, see, this is the 3D contrast.
Yeah.
Why 3D contrast? Let me tell you. See, onus is on the surgeon again to order what kind of imaging. Because you order MRI brain, the radiologist will do MRI brain, 1 or 2 sequence.
Yes.
1 or 2 printout, that's it. Why would he bother doing MRI for an hour? Unless you ask for. So what we ask in this particular situation, see kind of MRI, see how many sequences we have got done. This was 3D, Fiesta image, what we have seen, 3D, all 3D in all planes. Then the flare image to see if any infarction or anything in the brain. Once you suspect an acoustic neuroma in a larger tumor, see, you may have, larger tumor may give a brainstem or cerebellar or infarction anywhere. And the image which picks up earliest is the flare imaging. You must order, otherwise you will miss. Diffusion imaging is so important. Let me tell you, the diffusion is so important to know even earliest any infarction and to differentiate the masses in the CP angle. Like cholesteatoma shows diffusion retraction. Other tumors do not show diffusion retraction. So many things you can have for differential diagnosis because you can't order MRI again and again.
Yeah, right.
So diffusion is very important. Then contrast, we order 3D contrast. The beauty of 3D contrast is see the 1.5 mm section. You can't miss the lesion so easily. See the regular contrast. Let me show you. Even if you write the contrast MRI, they will do this contrast.